The fall 2025 season of Investigation with Dr. T is proudly centering on our institution's newly designated prestigious R1 Carnegie classification. We're seizing this moment to go deeper, think bigger, and highlight the game-changing work that's happening. So each episode this fall is going to spotlight cutting-edge research initiatives, groundbreaking studies, and powerful doctoral dissertations led by PhD and EDD students, research-engaged faculty, field-based research practitioners, and community partners. So we're going to focus on vital sectors like education, criminal justice, human services, while also welcoming special guests from the College of Psychology, College of Dental Medicine, and the College of Computing and Engineering. And join us as we celebrate our journey into R1 territory and explore what it truly means to lead with research, lead with scholarship, and lead with purpose. So stay tuned. Fall 2025 Investigation with Dr. T. It's going to be unforgettable.
So tonight we have Dr. Barbara Packer. We have Mr. Grant Wang. And we welcome Chetana Movva. And I am so super excited to welcome these amazing scholars and welcome everyone to the fall 2025 season of Investigation with Dr. T. And we're celebrating, as you heard, the recognition of our R1 Research Institution designation. But tonight, to kick off the season, we're spotlighting the next generation of scholars, our Razor's Edge undergrads. And these students, alongside our faculty and research partners, they're pushing boundaries in education, in healthcare, and the sciences. From exploring chronic fatigue syndrome to studying PTSD and EMT students, we're seeing research that's both academically rigorous and deeply human. And we're joined tonight by Dr. Barbara Packer, Chetana Movva, and Grant Wang, all who will share their innovative work and reflect on what it means to grow as researchers in an R1 institution. So Dr. Packer, we're going to start with you. You're an accomplished higher education leader and educated with over 3 decades of experience with NSU, and you currently serve as co-director of the Razor's Edge Global Scholars Program and assistant director of the Razor's Edge Research Scholars Program. And you provide vision there, strategic planning, and oversight for innovative undergraduate initiatives in research and global engagement. Welcome, Dr. Packer. Thank you for saying yes. And also, spotlit tonight is Ms. Chetana Movva from the Institute for Neuroimmune Medicine. She's a current senior in the Razor's Edge Research Program, dual DO program, and Honors College. And she currently double majors in English and biology with minors in research studies, honors, and pre-health. Listen to this, guys. Chetana was selected to be one of 4 students for the NIH U-RISE program at NSU. This past summer, Chetana presented her research on chronic fatigue syndrome that you're going to hear about tonight in Cambridge, United Kingdom. Also with us tonight is Grant Wang, College of Osteopathic Medicine. He's a junior at NSU, majoring in public health, minoring in research biology, and pre-health. He's a proud member of NSU's Razor's Research Program. He's originally from my hometown, New York. Grant became a New York State emergency medical technician at the age of 17. And since then, Grant has leveraged his license to gain national certification, engaged in various healthcare opportunities like private ambulance EMT, camp health director, and various healthcare opportunities. He's amazing, even a medical supervisor for amateur boxing and kickboxing exhibitions. But tonight, he's going to share some really important research about PTSD and EMT students. So while Chetana and Grant, welcome again. I'm so happy that you're here to kick off the season. But we're going to hear from Dr. Packer first, so you guys can just take a minute, and we're going to talk to Dr. Packer for a second. So look, Dr. Packer, research doesn't just happen at the graduate and faculty levels. It happens through programs like Razor's Edge. How does Razor's Edge help undergrads develop as leaders and researchers within an R1 institution?
Thank you, Dr. T. Can you hear me okay?
Yeah, we hear you great, and you look
Super.
great.
Oh, thank you. So, what I'd like to say is Razor's Edge Research is a scholarship program that was started about 9 years ago. And so we only accept 20 students each year into the Razor's Edge Research Program. And our decisions are made by looking at not only their high school transcripts, their SATs, their ACTs, interviews. We interview over 700 kids each year before we select only 20. These are kids that are really passionate about problem solving, investigating, learning about research, and challenging themselves to really find answers to difficult questions. Our students come to us from all over the country, and we have some international students as well. They are absolutely the best of the best. They could probably go anywhere in the country. Um, what I am very excited to tell you, Dr. T, is that we offer a 15 credit minor in research studies so that these students are really well prepared, unlike many other undergraduate students who are interested in research, in that we provide them with 9 credits of didactic classroom instruction where they study research methodology, research design, ethics of research. And my colleague, Dr. Mills, and I work really hard getting them prepared, not only through the coursework, but through some professional development activities centered in the areas of research. And we've been doing this, as I said to you, for about 9 years. So we have a number of wonderful graduates that we could certainly talk to you about. I could go on and on.
That's
But
great.
after these students complete this didactic 9 credits of research studies, we then place them with research faculty mentors across the institution. So if they're interested in dental medicine, we place them with a dental faculty member. The two that you're going to be meeting are very interested in totally different kinds of research. We have kids that are in marine bio, environmental sciences, education, psychology, and so on. And both Dr. Mills and I will tell you that not only at the end of our interview time slot, which is the winter semester when these kids are high school seniors coming to meet us, we're really excited about the future because these kids show that this world is going to be well researched and we will be filled with passionate kids that want to make a difference.
Awesome. I want to let you know that Dr. Mills is actually on, and what he said to us to let us know is that he's watching with 20 of us in stats are watching our classmates. So that's awesome. So, Dr. Packer, what unique challenges and opportunities come with mentoring undergrads in high-level research projects like the ones that we're going to hear about tonight?
Some of the challenges might surprise some of you. It isn't that they're not bright enough or cognitively ready or prepared for studying research, but we always have to step back and remind ourselves that while they're capable of doing all kinds of amazing things in research, they're still young people. They come to us, most of them, when they're 17 or 18. So they have all the challenges of undergraduates that are going to institutions across the country. Whether it is, just not really being comfortable living away from home for the first time, whether it's challenges with social skills and things of that nature, we have to step back and say, even though these kids are well prepared, we also have to teach them some of the soft skills that make their professional development important. And we work really hard on that as well.
Awesome. Last question for you, Dr. Packer. Can you share a story of an undergrad who surprised you with the impact of their research or leadership work?
So, okay. Dr. T, that's like asking a parent to tell you who their favorite child is.
Sorry.
So I'm going to talk to you about people that have finished the program.
Okay.
We,
Or you could talk about the two that are on tonight, but I'm not
oh,
gonna I'm not gonna tell you what to say. Go ahead.
those two will obviously wow you. But for example, we have had two that come to mind that were medical students. One went on to a combination research medical degree program. He is in an MS/MD program at UC San Francisco, Berkeley. It's a combination degree where he will be a researcher and a physician. We have another student who, because of his research, was selected at Johns Hopkins for a full ride, and he's in touch with us all of the time. We have people that have gone in marine science to places like New Zealand to study, and Australia and the Great Barrier Reef. Some of the interesting stories, though, and I will share only one because he comes to my mind frequently. He thought that he wanted to be a doctor, discovered during his research and stats and other activities that he did in coursework that his real love was in mathematics. He went on, after doing some research in math here at NSU, to the PhD program at UNC Chapel Hill, and he is on his way to becoming a PhD mathematics professor. So the journey takes different forms for each of our students, and we're excited to see where we lead them and where they lead us.
Thank you. Thank you. Thank you. And Dr. Packer, we're going to have you back for the end for Q&A. And thank you so much again for
Thank
arranging
you.
all of this with me and for being
Um,
here tonight. We are so appreciative of all the work that you do and the
thank
leadership
you.
and the mentorship that you provide. So
Thanks. Can't
thank you.
wait
Thank
for you
you.
to meet our students.
Yes. Thank you so much. Thank
Thanks.
you. So we're going to ask for Chetana Movva to come on down. And as I gave her bio already to you tonight, she's going to talk about something very fascinating, very fascinating. Now let's see. I've been practicing it all day long, so she's going to talk about myalgic encephalomyelitis. How did I do? How did I do, Chet?
Great. You did
Yeah,
great.
yeah. Which is also known as chronic fatigue syndrome, right?
Yes, it is.
So she's going to share her presentation. It's going to be about 10 minutes. And then we're going to go into some questions directly to you about your research. So take it away.
Amazing. Thank you guys so much. And thank you, Dr. T. That was a great introduction. So hi, everyone. My name is Chetana. I'll be talking to you today about telomere attrition in CD4, CD8, B, and NK cells of ME/CFS patients. And this is a pilot project, by the way. Just want to say, quick disclaimer, if some of this stuff goes over your head, don't worry about it. I'll try to explain it as much as I can. But overall, I'll be going over the disease of ME/CFS and what our pilot project is kind of about. So again, my name is Chetana Movva. You can kind of see it here. My main mentor is Dr. Lubov Nathanson, and I work at the INM Institute, which is the Institute for Neuroimmune Medicine at this Center for Collaborative Research. Okay, so what is ME/CFS? ME/CFS is otherwise known as chronic fatigue syndrome. So the complicated name that Dr. T was trying to say is myalgic encephalomyelitis, and she did great. So it's a serious and often long-lasting illness that keeps people from doing their usual activities. It's estimated that around 5 to 9 million Americans suffer from ME/CFS and around 17 to 24 million people with ME/CFS worldwide. So basically, it makes physical and mental exertion very difficult, and symptoms include trouble thinking, severe tiredness, within a host of other symptoms. So I just want to emphasize that there's no cause or cure that is like distinctly known. So that is why research is so important for all these individuals that suffer from ME/CFS. And I just want to take a minute and just have you like theorize for a minute. Imagine you get sick one time. Say, for example, you get sick with the flu and you're feeling really tired, you're coughing, you're sneezing, et cetera, et cetera. You're just not feeling your best. You have a horrible week. you might recover. You recover at the end of the week. But imagine that you get sick for the second time, months or years later, and yeah, you might stop coughing and sneezing, but you don't get rid of the fatigue ever. And that's how people with ME/CFS live their lives. So they a lot of times can't go to school, they can't go to work, they can't take care of their family, they can't take care of their kids. Their livelihood is extremely just diminished, like from what it was before. So I think it's a very important thing to just to overall consider how we view people with ME/CFS. A lot of them are written off as lazy or they just don't want to work or et cetera, et cetera. But it is a very biologically rooted condition that we as a society should consider paying more attention to, and more research definitely has to go into it. Dr. T mentioned that I went to Cambridge this summer. And this is the presentation that I did at Cambridge, and it was a conference for ME/CFS researchers. So it was really eye-opening to see the research going on with ME/CFS, which is very closely linked to long COVID, if you guys have heard of long COVID. So they're very closely linked, and a lot of the pathology is very similar. But I will say that I am very optimistic for the future of ME/CFS research, because there are many researchers and many young researchers working on it. Although it's a very small subset of researchers, they often share their results, and there's a really big community there, and a really strong community there. So yeah, just a background. So really quickly, why is it so hard to diagnose? A lot of other conditions with similar symptoms need to be ruled out first. So people with ME/CFS are often found to have biological abnormalities, but none of these biomarkers have had sufficient sensitivity and specificity to constitute a diagnostic test. So we can say, surefire, you have ME/CFS based on a test we do in the lab. It doesn't work like that. A lot of it is based on symptomology. So yeah, that's just a quick background on ME/CFS. Let's move forward. So the background for our study, like I mentioned, I just want to quickly go over it again: telomere attrition in CD4, CD8 plus T cells, B and NK cells. So quickly to give you an overview of what these cells are. So these are lymphocytes. Lymphocytes work in your body to fight against inflammation, to just basically keep you healthy. They're your body's immune cells, to put it very simply. So all these cell types are closely linked to ME/CFS, and this is a background study that has been done previously. So basically, another part of the main part of the study is telomeres. So telomeres are the end caps of your DNA that, as you continue to age, your telomeres continue to shorten. So an aging individual or an older individual would have shorter telomeres than a younger person. So telomeres essentially equals aging. Like the shorter your telomeres are, the more aged you are. So just putting that out there. So the background of this study, so Rajiv et al. Was a group of researchers that performed a study in 2018, and they also reviewed telomere length in whole blood within these same lymphocytes. And they found actually that if you can see with the purple line here, that non-fatigued controls had significantly longer telomeres. So that was kind of the basis of our study. It was very interesting to kind of read that study. So what was found is that the telomere length in ME/CFS and ISF, so the telomere length in CFS and CFSX and ISF were significantly lower than in non-fatigued controls, which is NF. So yeah, so that's a background of our study. This will work. Okay, so background: continued chronic immune activation, which is known to be a contributing factor in the etiology of ME/CFS, leads to a wide array of issues such as CD8 plus T cell exhaustion. This is just a quick model just to show you how exactly a CD8 plus T cell can kind of become an exhausted T cell. So we're asking, what does telomere attrition look like in the PBMC subtypes of ME/CFS patients? So our study utilized two cohorts, one American cohort and one from the Spanish cohort. So this is because ME/CFS, like I said, is hard to diagnose. So we actually had a very small sample size. If you see here, if you guys have a background in research, you might know that this is a very small sample size, 15 healthy controls and 15 patients. But but that had to be done because this also is a pilot study. So just keep that in mind. Don't write it off yet. So the American cohort was recruited from NSU's Neuroimmune Institute, and the Spanish cohort was collected from Spain in the biobank of the Catholic University of Valencia. All the participants met the international diagnosis criteria for ME/CFS. Just quickly going over sample size and our study cohort. So next, I want to go over what exactly we did to isolate the cells so that we could actually measure the telomere attrition and the specific cell subtypes. So for the Spanish cohort, we used FACS, or fluorescence activated cell sorting. Really complex process for saying that essentially there's antibodies that we labeled on each specific cell type, and we were able to separate them through fluorescence activated cell sorting, which is actually when cells are passed through this a really complex machine called a flow cytometer, and from there the cells will get sorted. So we're essentially, and during these process, we're just trying to isolate CD4 plus, CD8 plus, NK, and B cells because they're all kind of mixed up. So we got to separate them first. So that was for the Spanish cohort, and for the American cohort, we did MAX, which is magnetic activated cell sorting. Similar process, maybe a little bit more interesting in my opinion. So in this case, we actually isolate each of the cell types magnetically. So they're magnetically retained, and we throw away the unwanted cell types from like a population of, like, we just split up all the cells into 4 tubes, and we separate them magnetically. So that's the same thing. So essentially from both cohorts, they were just magnetically or fluorescently separated. And now we have 4 different groups of cells exactly as we wanted. So the next thing is the primer design. Primers are used when you're doing PCR. So PCR is a technique that allows you to grow a DNA chain. So telomere is made of DNA. So that's why we want to essentially grow the telomeres to a certain point so that they can be detected by a machine that will then allow us to see what is the relative length of telomeres in each of these cell subtypes. This is just the primer design. Then the telomere length. So I just kind of quickly explained to you what cycle threshold is but not saying cycle threshold, but it's essentially when a large amount of DNA is in a sample, you'll need fewer cycles of PCR for the detection of the DNA. So the larger amounts of DNA means you need fewer cycles. Smaller amounts of DNA, you need more cycles, so you'll have a higher cycle threshold. So higher CT values or delta CT values essentially indicates longer relative telomere lengths. So you can kind of just see what a curve would possibly look like if we did it. This is just an outline of our plate just to kind of show you our variability and a reduced technical bias. So this is kind of like, essentially imagine this is like a huge 64 well plate, and you just kind of pipette each of these different samples in there. So when we put this into the machine, it's going to read it, and then it's going to tell us essentially how long our telomeres are. So, oh, okay. Yeah, next slide. And so these are our results. So just really quickly thinking, right? So our hypothesis was that telomeres in patients in all subtypes would ideally be shorter, because we expected that the lymphocytes of patients would have shorter telomeres or aged telomeres. We essentially thought that these 4 cell types were getting exhausted more quickly because ME/CFS is a chronic immune condition where you're chronically inflamed. So that's the whole point of it. So we were like, okay, so all of the cell subtypes are probably going to have shorter telomeres. That's what we thought, even according to the background study that we did that we referenced before. But we actually found that CD8 plus T cells, or CD8 plus CD8 T cells from ME/CFS patients have longer telomeres, significantly longer telomeres. And I say significantly, like statistically significantly longer telomeres than those from the healthy controls. And it's also worth noting that CD4 plus and NK cells also displayed a similar correlation between the telomeres of patients and healthy controls, and B cells were the opposite. However, their p-values did not cross the threshold. So that's why we just want to focus on CD8 plus T cells. But you can kind of wonder why, right? Like, this is such a surprising result. Why are they less aged than the healthy controls? So kind of let's go into explaining that. So there are some proposed explanations. So this is kind of a model from going from naive to a full CD8 plus T cell. So there could be some potential reversion of CD8 plus T cells to a stem-like state. There could also be reduced mTOR activity shifts from metabolism from glycolysis to fatty acid oxidation. IL-7 resets chromatin to a stem-like state, or sustained expression of PD-1 promotes metabolic quiescence, favoring survival over effector function. So there's a bunch of reasons that even I did not understand completely when I was first researching this. So essentially, this is our kind of wrapping it up. To date, only one study has been performed on telomere attrition in ME/CFS. So we did a pilot project to do this, not from whole blood like the original study did, but from specifically PBMCs. And our pilot project showed that further research is definitely needed to draw a definitive conclusion on telomere attrition in ME/CFS, and furthermore, testable predictions can be made to support the proposed explanations. So just quickly acknowledging some of our amazing people that have contributed to this study. Like I said, I work at the Institute for Neuroimmune Medicine. We collabed with the University of Catholic University of Valencia. Like Dr. T mentioned, I was in the NIH URISE program at NSU until it got unfortunately terminated. So yeah, that was unfortunate. But yeah, so like I said, these are our main contributors. Dr. Lubov Nathanson is my head PI or principal investigator, and she's an amazing mentor to work with. So, and this is where I work. So yeah, that is my study, and these are my references. And I'll go ahead and stop sharing now. But yeah, I hope you guys have. I hope that was interesting for you guys. It's definitely interesting for me. And sorry, I went a little bit over time there.
No, you're fine. You're fine. Thank you. So now you've explained to me why I'm aging. My telomeres
Yes.
are shortening. Is that what you're saying? Yeah?
Telomeres are a marker for aging. So if I looked at your telomeres versus if I looked at, for example, my telomeres, your telomeres would be shorter. So I could like look at some telomeres like that and I could tell you who's older, but yeah.
Yeah, because I'm already short. I'm already shorter, and just not anyway. Wonderful, wonderful, and very, very important research. Why? Because chronic fatigue is often misunderstood and underdiagnosed, right? So there's no really diagnostic test for it except the symptoms. And often folks have been stigmatized for it. And it's like, oh, yeah, yeah, okay, right. You're just being lazy or something like that, right? So, based on your research, what do you think are the most important insights or misconceptions that need to be addressed in both the medical and public spheres?
Yeah, this is a great question, and I think this actually came up a lot during the conference. Um, so a lot of people, like I kind of mentioned earlier in my slides, that people are kind of dismiss chronic fatigue syndrome as people being lazy or people not wanting to work. And I think it's rooted in a general misconception people have about chronic illnesses. The thing is they're not immediate, they're not sudden, but they are long lasting and they affect multiple aspects of your life, including your livelihood, family, school, work, the things that kind of make us want to get up in the morning and go achieve something, right? So if you're bedridden and if you're not able to even like make yourself like become unfatigued, you're just tired all the time. Imagine your worst week during undergrad, or imagine your worst week during your job and you just feel super tired, you don't want to do anything. Imagine that happening all the time. So it's hard to even wrap your brain around because we're not used to it. So if anything, we should as a society just kind of come together and pay more attention and drive more research towards chronic illnesses, not only chronic fatigue syndrome, but all chronic illnesses. And as a society, recognizing that chronic illnesses also look different. It's not always the same thing. Just because you have a chronic illness, it's obviously not going to be the same as someone else's chronic illness. Yeah, and being more individualistic in that manner, and just being open-minded, and definitely putting more funding into research, 1000%. Even during this past conference, they were discussing decreases in research into long COVID, even decreases into research in COVID in general, like not even supplying the funds for that research. So I mean, that's just mind-blowing to me as someone who knows how related long COVID is to ME/CFS. Yeah, it's mind-blowing. So moving forward, definitely putting more money into research.
Yeah, and I think that I said this before during the pre-production part of our live stream tonight, that I feel such hope when I see folks like you and Grant and other undergrads who are brilliant and motivated and passionate about research, and that you're the change that we need. And so there's going to be some challenges, and it's going to be a little bit of an uphill struggle around research funding, I think, in our climate right now. But if anyone's up for the challenge, it's going to be you. And so I still have hope. But let me ask you about your work as an undergrad researcher. You're contributing to a field that affects millions worldwide. How has studying this chronic fatigue shaped your own perspective on the role of research in improving quality of life for patients with these complex conditions?
Yeah, I think that's a really great question. And I know I'm a little over time, so I'll try to address it quickly. But research is absolutely fundamental to medicine. There is no medicine without research. There is no research, I guess, without medicine too. Like they both kind of contribute to each other. And both fields, like the discoveries kind of bridge together in creating actual patient care. Because even after medicine and you have clinical trials, you have randomized clinical trials, that's still research. That's still a component of research. So I mean, I think people kind of separate medicine and research, but they're so intertwined. So as someone who wants to become a physician, and even for anyone else that wants to become a physician, like learning about the importance of research is an invaluable skill. So I think it has definitely affected me. There was periods where I even wanted to do MD PhD, but anyways, I just want to become a doctor now, but
Well, don't forget us. Don't forget us when you become a doctor. Thank you so much. We're going to have you come back for Q&A. But thank you again for your brilliant work and an excellent presentation. Thank you. Thank you.
Thank
And
you
I'm
so
going to
much.
ask for your colleague now, Mr. Grant Wang, to please come on. And Grant, are you ready?
I am so
Are
ready.
you ready for prime time?
Oh,
My New
I'm totally
Yorker?
ready. Oh yeah, I got this.
Okay.
Nice to meet you all, you guys. My name's Grant. I'm really, really thankful to be on the show right now with you guys. I've been looking forward to this for about since the summer actually. So yeah, I really hope that I get to show up for all of you guys and you guys really get something out of this. At a
Yes.
time
Well,
where, research is getting pulled from a lot of different areas. I find that this is probably one of the most important ways to really show up for research. So yeah, without further ado, let me see if I can just share.
100%. While you're sharing that, Grant, I'm just going to introduce your topic is assessment of PTSD in EMT students using the PCL-5 checklist. So it's all you now.
Okay. And good to go. All right. So, hi guys. My name is Grant. I'm a junior at Nova Southeastern University. I major in public health and I minor in pre-health biology and research. The topic today that I'm going to be discussing is my research with the Osteopathic Medicine College here at Nova Southeastern. We are going to be talking about incidence rates of PTSD in EMS students. So yeah, let's get into it. A little bit. Oh, might have skipped a slide. All right. A little brief history on EMS. EMS actually started out in hearses, believe it or not. So if you were really hurt or really injured, the first thing you're going to see is a hearse, which is not really the best thing to see, especially when you're in your most vulnerable moment, possibly a life or death situation. And yeah, the guys that were driving around these hearses weren't trained EMTs or paramedics just yet. They were actually funeral directors and firefighters. So yeah, not a really good look, but statistically speaking, it also wasn't really helpful. In the 60s and 70s, research came out that there were a lot of preventable deaths that occurred on these hearses, and the reasons were a lack of training, a lack of resources, etc. So in 1967, Pittsburgh actually formulated the first paramedic team. They had the first successful infield intubation. And it was actually a really successful pilot. And following that, EMS would blow up. It would be all over the country. It would start out in California and slowly start making its way from the West Coast to the East Coast. And now there are actually 282,000 paramedics and EMTs within our country. So what started out within hearses became a multi-billion-dollar industry. But unfortunately, it's not so clean cut like that. As it would turn out, we have a number of challenges to the modern first responder. The first one would be financial stability. EMTs within the United States make on average about $40,000 a year. This is only $10,000 above the federal poverty level income for a family of four. These first responders deal with a number of things that you wouldn't really expect healthcare workers to deal with. They're challenged by food insecurity, challenged by housing insecurity and healthcare issues. Most importantly, these financial instability makes it so that a lot of EMTs and paramedics can't really sustain a career within EMS just simply due to the salary. As you guys know, I'm able to use my EMT certification for a number of different jobs within the professional market. And that's because the skill set is actually a lot more useful than most people would expect. But the salary working in private and commercial ambulance doesn't compensate for that skill set. I've gotten paid more as a ringside medic than I have as an EMT on an ambulance. And so as a result, there's a massive shortage in the United States right now with paramedics and EMTs. The second thing is patient aggression. Canadian study that had a survey of about 1,500 participants found that 26% of first responders have been physically assaulted and 3% have been sexually assaulted. Yeah, patient aggression is a real thing. Not everybody that you're going to bring onto the ambulance is in their best state of mind. Some of them are coming in as intoxication patients. Some of them are coming in as emotionally distressed patients, which can pose a danger to the first responder. I've gotten multiple incidents where I've almost been clocked in the face or I've been kicked at, and it's not always the prettiest job in the world when your patient isn't uh, uh, really acting like a patient. Then we also have occupational injuries. In 2020, 16,000 to 22,000 EMS responders received ER treatment. Majority of this is actually due to sprains and lifting related injuries. My own experience with that is that, yeah, back injuries happen a lot on the job. I came down to college after a month the whole summer working EMS, and I was in pain like the entire drive down from New York to Florida, to the point where my friends that were helping me drive would actually pretty much take the wheel for like 70% of the trip, simply because I was just in pain sitting there. And transmission of disease. This is one that not a lot of people would expect because we have a lot of personal protection equipment on the ambulance. We have gloves, we have scrubs, and we have a lot of training that discusses how to deal with needles and bodily fluids. But despite that, sometimes your precautions won't really be enough. And a good example is during COVID, when 13% of New York City EMTs were infected with COVID in the first month. And the next month of April, 24% were on sick leave by the first week. So the capacity for not only bodily harm, but physical illness is also something to note. Next up, we're going to be talking about post-traumatic stress disorder. So PTSD is defined as a mental health disorder that follows a serious traumatic exposure. It can result in more minimal stuff like withdrawal from social interactions, but it can also really manifest in more mild symptoms like depression and anxiety. And finally, into more severe cases, you have recurrent nightmares, violent outbursts, and even substance abuse. So the risk of PTSD is heightened, especially because EMT and paramedics have what's called a random. The capacity for traumatic exposure is entirely random. You don't really know when you're going to get your call. You don't really know how bad it's going to be. You could be sleeping or you could be at lunch and you could get called out immediately to something that could be either a 9-year-old with a tummy ache or a 20-year-old involved in a motor vehicle accident. The entire randomness and chance of a traumatic exposure really has you on your feet the whole time. And as a result, that hypervigilant state that you're being on shift for maybe 8 hours, 12 hours, maybe even 24 hours, all of that starts to wear down on your mental resilience over consistent shifts, years on the job. And finally, what will come is a traumatic exposure that you don't really have the mental resilience for. And as a result, you can contract PTSD from that. PTSD is contracted from repeated traumatic exposure as well. So even though the job might train you to become more resilient with what you're seeing and become more desensitized to it, unfortunately, the specifications of the job itself can really start to chip away. And if you remember the challenges we were talking about on the last slide, those equally contribute as well to the mental health strain that is going on in the background of our first responders. Something interesting to note is the psychiatric profile of a first responder. They've done a few studies actually on what are like the makings of the average first responder. These guys have, funny enough, they have really poor impulse control, which is not something you would expect for a first responder, but it's true because a lot of guys that become first responders are adrenaline junkies. They love everything from the sirens to just flying around town. And I can say for myself that I sort of fall into that category. But then there's also the altruists as well who love to give back to their community and everything like that. So for the altruists, they generally have a much more challenging time within traumatic exposures because they really care for their patients and they're really dedicated. And when they get a bad call or the patient doesn't make it, they are seriously affected. It's also really important to note that a lot of first responders are categorized as perfectionists. So if they're really doing the best they can and the outcome is unchanged, they take it out on themselves more often than not. And lastly is the unresolved closure of the patient. Pre-hospital care is fast. It's really, really fast. You get to know your patient for maybe like 10, 15 minutes before they're all the way in the ER, and you sign a document and they are gone. So you don't really get to know what happens to your patients. And in those worst cases, that idea of not really knowing what happened in spite of your intervention can really weigh on you. All right. So PTSD and EMTs and paramedics, there exists a plethora of evidence regarding occupational traumatic exposure within EMS to PTSD incidence rates. So a good number of first responders deal with occupational stress. The stressors, the challenges that I've explained are really the majority of them. I don't really think I'm leaving anything out. 41.5% of first responders communicate within surveys that they experience occupational related stress. 82 to 100% of first responders have had a traumatic exposure, and 90% of participants within the study regarding the occupational related stress demonstrated signs of burnout. Interestingly enough, burnout has a positive correlation to the number of years of service within EMS. So the more likely you are, the more time you have on the ambulance, the more likely you are to actually get burnout, which not many people would think because you would expect that you become more desensitized over time, but it all stacks up. And studies agree that PTSD in EMS first responders is valued at approximately 20% of the general EMS population. This is a good median number. Some studies say as low as 13%. Some studies average almost at 35%. So the median agreement is that it's about 20%. International studies as well have come to the conclusion that it's about 22%. Interestingly, these international studies use a tool called the PCL5. The PCL5 was a PTSD assessment tool developed by the United States Department of Veteran Affairs. It's a really effective tool at analyzing PTSD-associated symptoms. It requires a psychiatrist to interpret the results, and it's well in line with the DSM-5 psychological studies manual. So it is a pretty airtight tool that yields pretty confident results. So I want to do a little thought experiment here, right? So if you guys want, you guys can close your eyes and imagine like the Wild West cowboy. The Wild West cowboy is like, like this rough and tough American that tumbles into like a desolate town. And this guy is, he rolls up knowing the danger and he saves all the townsfolk and then he leaves, right? That's not really how cowboys were, right? Hollywood puts on that narrative that cowboys were like these heroes when in reality they were just ranch hands. I feel like nowadays what the problem with Hollywood today is that they've made EMS, first responders, cops, firefighters, all these guys, they've kind of turned them into the cowboy, right? I'm not these guys for sure do some really good and awesome stuff, but they set unrealistic and dangerous expectations for what a first responder job is like. And for guys that are, infatuated with like the Hollywood narrative of what it means to be a first responder and they apply and they get a career in EMS, the implications of not really having those realistic expectations can often be dangerous because you might not be mentally prepared for what it is you're about to see. Okay, so here's my study. So in all my research and performing my literature review and sorting through about 50 different studies on EMS PTSD incidence rates, what's interesting is that no research is really done on the students. A few research studies are done on paramedic students, which are at the higher level of EMS, but very little research is done on EMT students. EMT students are at the basis level, whereas paramedics usually have a lot of experience within EMS being previously EMTs. It's important to note that because of that, they have a lot more resistance as well to traumatic exposure. They're more desensitized. So it's really weird that there's like no research done on the people that enter into EMS. So in knowing that, I decided to pair up with Dr. Professor Megan Colas of the Osteopathic Medicine College at Nova. And we wanted to kind of really take a look at local EMS students, specifically the EMTs that are looking to get into their first rounds of clinicals and check out whether or not they're really getting any PTSD associated symptoms from their first introduction to EMS. The first stage required a literature review to gain IRB approval for the research. I sorted and compiled through dozens of resources, including international studies, and I would present my findings at Razor's Research Symposium in the spring. After presenting my foundational knowledge, I would work pretty closely with Dr. Professor Colas to formulate a good methodology in addition to reaching out to local fire academies. So right now, the methodology is as follows. We are originally going to do a pre-test post-test design, but unfortunately, research can actually show that giving indicators of what PTSD is at the beginning of a course or a class can cause what's called pre-test sensitization, wherein it's similar to hypochondriacs, where when they have knowledge of a disease, they almost start to gravitate and be like, oh, that's a sign of PTSD. Oh, that's a sign of PTSD. And that can really skew results. So what we're going to do is that we're going to operate a post-test design and give our PTSD assessment after the clinicals. We're going to use the PCL5 checklist. As I mentioned before, it's a really solid PTSD assessment tool. It's used all across the world, not just in the United States, but they've used it in Taiwan, in Iraq, and other countries, and including the UK as well, to really assess PTSD within first responders. And what's interesting to note is that our sample group won't only just include citizens becoming EMTs, but it'll also include firefighters that want to become EMTs. Down here in Broward County, it's very utilitarian. A lot of firefighters also hold paramedic and EMT licenses so that when they get to a motor vehicle accident, not only can they help extricate, but they can also, render healthcare intervention, which is really neat stuff. But it's kind of a pain in the butt for our research study, admittedly, because firefighters going into EMT course already have a bunch of experience within first responding. They have dramatic exposure that could confound our evidence and kind of skew the results, but they also could have more resilience to what a lot of dramatic exposure can be going on. So as a result, we're going to be implementing a life checklist called the Criterion A. It's going to precede the PCL5 checklist, and it's going to give a really neat timeline of traumatic exposures that were important to that participant in the past. And then finally, we're actually going to be implementing PTSD education personally. The chief of Broward County Fire Academy actually reached out to us, and he was all like, he wanted us to really give a lecture on PTSD education within their classes. So that's pretty neat stuff. But again, it's possible that it might have some confounding results within the study, but that requires more investigation. And now for the results. Unfortunately, the study is actually still in progress. We don't really, know what's going to happen with the study at the moment. We have some certain expectations of what can happen based on previous studies and things of the sort, but at the moment, we're still waiting on these EMS classes to bring their new EMTs onto clinicals and ride-alongs. So what we can kind of give some good ideas of is that the citizens becoming EMTs will more than likely have about an 8 to 10% associated PTSD symptom. This is solely based off the fact that paramedic students have 8% PTSD incidence rate, but because paramedics, of course, have base training as an EMT and they've had more time on the ambulance, they are, I would imagine a citizen EMT would probably have a bit more challenge, having not been exposed to such traumatic stuff in any previous occupation or experience. And as for the firefighters becoming EMTs, I would argue that they would most likely have negligible PTSD effects simply because they've had so much time on, first responders and whatnot. So yeah, these are my citations. I hope it was really good and you guys enjoyed it. I definitely enjoyed presenting to you guys, and I appreciate all of your guys' time. Special shout out to Dr. Grace Telesco and Dr. Packer for helping me, giving me this opportunity to really speak on something that I find really important. So yeah, thank you guys.
Thank you, thank you, thank you, Grant. Now, actually, I had a couple of questions already in mind for you, but you've already answered them in your presentation. So thank you for that. PTSD is something that is near and dear to me as a first responder, as a ground zero first responder for a year and a half, being at ground zero and seeing my cops, really unravel emotionally. Not right away, not while they were involved in the cowboy stuff. It's later. It's when you start looking at stuff in the rearview mirror and you've retired, is when things start really emerging. So it's really interesting and fascinating work. And I know that Dr. Mills is involved with PTSD and veterans, and we're actually going to have Dr. Mills next Thursday. He's going to be on with me to talk about September 11th. Never forget. And then he's also going to be on to talk about his research. So PTSD topic is fascinating and near and dear to me. Thank you, Grant, for a fabulous presentation. I'm going to ask for your colleagues now to come all back. We'll get Dr. Packer spotlit, and we will get Chetana also spotlit. And we're going to just go right to Q&A because it's 7:54 and we have a couple of little logistical things that we usually do at the end. So to make it, it was jam-packed, right? You guys nailed it. Home run. I'm getting a lot of people texting me saying how impressed they are with you and what scholars you are. And so Dr. Packer must be beaming with pride at this moment. And I'm just really thrilled. So I'm going to ask, go ahead, Dr. Packer, you want to say something? Go ahead.
Yes, I want you to know, Dr. T, that this is 2 of 80 students, all of whom could present in their areas of passion. And so I just want to highlight that I am super proud of these kids, what they've accomplished, and hope that a little bit of what Dr. Mills and I have done along the way have made a small difference in their development. And as you can see, how can you not be proud of these kids?
Yeah, absolutely. Absolutely. So I'm going to ask for my two project managers to come on. And, I didn't even know that Ethan is, let's see, can I get Ethan on for a minute? Ethan Mang. Um, I'm just going to spotlight you for a second because you also are a Razor's Edge scholar.
I
Yeah?
am.
Yeah?
Yes, I'm a Razor's Edge research scholar.
Yeah, I didn't know that, and it's a first. Like Eddie Hammonds, who's been with me now for a few years, is a Fischler Academy representative, Fischler Academy in the house, and is the team captain here of our production team. And Ethan has joined us as a med student, as pre-med, and as a Razor's Edge scholar. So I'm thrilled. So Ethan and Eddie are going to field two questions each. One from the webinar, well, two from the webinar and two from YouTube. So I'm going to take myself off so there's not that many squares. And who's going to go first, Eddie or Ethan?
I'll let Eddie go first.
Yeah, I was gonna
Okay,
go
Eddie will go
first.
first.
So there were no questions from the YouTube, just a lot of people saying that you guys did amazing and they loved your presentations. So I'm also gonna pick two questions from the webinar.
Okay, excellent. Good. Go for it.
So
And somebody's hand is up right now. So
yes,
while you're
I
waiting,
was
go ahead. Sorry, Eddie, go.
I think I see whose hand has been up and I was gonna ask their question anyways, so they're
Excellent.
good.
So do you want me to allow Delilah to talk, or you're just going to ask the question for Delilah?
I have the whole question written down,
Excellent.
so
Go. Yeah.
okay. So Delilah, this was a question for Grant. She said she found your research on EMTs very interesting, as this is not a field or topic that I have read or learned a lot about. I heard you mention the men in this field, specifically in regards to how these jobs represent cowboys, disorders like PTSD, the males within the jobs can develop, and how some males in this field are adrenaline junkies. Is this research specific to the male experience in this field, or do you think it applies to the female experience within this job as well?
Wow, that's
That's
a
a
good
great
question.
question.
Good.
Yeah. So when I was actually creating the presentation, I really try to stay away from gender normative discussions. So I was like, I talked about like imagine like the American, right? Like kind of using like gender neutral terms because I didn't really want to like just classify it to more masculine norms because admittedly, like the majority of first responders fall within the male category, but I wouldn't say that it is a gender normative thing. I'd say it's an all-encompassing category that the narrative from Hollywood tries to push onto first responders. Yeah, I really wouldn't say it's just a masculine thing, although rambunctiousness and things of that sort kind of are associated more with males. For example, ADHD for a while there was really only believed to have only been diagnosable within boys for about like during the 20th century. And then, yeah, I don't think that it's necessarily just a male thing.
I'm going to quick jump in. But Grant, I'm sure you're going to be looking at variables like gender differences when you complete all of your results. Is that accurate?
Um, that's a good question. I'm not really confident to say that the study needs to really look into gender variables. Um, but now that you mention it, I don't think it's a poor choice to give it some more thought. It was never really intended for within when we were setting up the methodology for the study, but admittedly, I do know that I have actually been reading a little bit. Women, for example, have a higher stress tolerance due to the dendrite coatings that they have. I know for a fact that a natural biological mechanism for women to have less painful childbirths was that they would have uh, I'm losing my train of thought here, but I know for a fact that there are a lot of biological mechanisms that play into stress resiliency and that favor towards women. So that's actually not a bad idea to consider within my study.
Great. Okay. Eddie, who's up
Okay.
next?
So, and then this will be
Chetana?
the last. I have two for Grant, and then Ethan has two for Chetna.
All
So
right, so
everyone's
let's
getting a
get
question.
okay, let's get Chetna out here, and then Ethan can ask Chetna the question, and then we can come back to Grant.
Okay, yeah, I had a question from Steven Serfos, and it is ME/CFS only the result of illnesses such as the flu or COVID, like you mentioned, or can it develop independently?
Yeah, that's a great question. So, the viral method of getting ME/CFS is one possible way to get ME/CFS. For a lot of people, ME/CFS kind of just like people just get it, and it's kind of like the actual cause, like I said, is not solidified. There is not just one cause. There could be a variety of causes. You can also develop it through your lifetime. So I just gave the viral example as like you getting a viral illness and then you falling like through fatigue um and continuing to be fatigued after the second viral load. That is just one possible way to get ME/CFS. But great question. It's still being studied, to answer your question. So yes.
Excellent, excellent. So now we're gonna tag team and go to Grant, back to Eddie to ask the question of Grant.
So for Grant, George Tavares asked, will your research study differentiate the difference between EMTs that work in busier cities like NYC, where EMTs are more prone to deal with traumatic medical emergencies compared to those who work in slower cities?
That's a great question. For right now, our pilot study is going to be held specifically to Broward County. Broward County is, I'd say, honestly, probably one of the more busier counties, especially. We're right there by Miami, and we have a huge population here in Broward. I would argue that if the pilot study goes well here within Broward, we could see potential for trying out near Miami, and getting that really good reference point for more urban and busier sections of Florida. But in terms of taking it out of state, I don't see that as a realistic possibility until we get some better results and secure some really good backing for that. But great question.
And finally, Ethan. Where are you, Ethan?
Yeah, here I am.
Okay, good.
All right, and the second question for Chetana was from Sophia, and it says, how prevalent would you say that chronic fatigue occurs in the average individual, and how easily can it be treated? This is kind of personal to me, and I would appreciate any additional information that you could give to the average layperson.
Okay, great question, Sophia. Thank you for your question, and I appreciate you sharing that it's personal to you. For a lot of people, like we might know someone with ME/CFS, so I mean, it is a very prevalent condition. I put briefly in my slides that in the US, it affects from roughly 5 to 9 million people, ME/CFS, so chronic fatigue syndrome. And throughout the world, 17 to 24 million people are affected by chronic fatigue syndrome. And I believe you also mentioned, Ethan, if you don't mind repeating, if also mentioned like how to treat it, correct?
Yeah, I can. Do you want me to reread the whole question?
Yes, please. Thank you.
It was, how prevalent would you say that chronic fatigue occurs in the average individual, and how easily can it be treated?
Okay.
Yeah.
Perfect. So there is a lot of research also going on as to how you can actually treat ME/CFS. The short answer is there is no like complete treatment. A lot of it is kind of these practices that you would see to better someone's livelihood or lifestyle. So including yoga, meditation, cognitive behavioral therapy. We have seen some results in that. And if you email me, I would be happy to I'm coming from a very lay perspective compared to people that have been studying ME/CFS their whole lives, because I've only been in the lab for the past 3 years. But I would be happy to kind of go over with you like what I know so far if you like. There's lots of literature on it, but I will say that like for ME/CFS, the treatment is not conclusive. A lot of people, the core part of treating ME/CFS is treating the symptoms. You don't treat the underlying cause, which is what research like mine is trying to move towards, like treating the underlying cause, treating the biological part of it, but a lot of it is treating the symptoms. So if you're tired, how do you fix that? If you're like, fatigued, how do you fix that? If you cannot get up in the morning because of you're tired, how do you fix that? Or if you're depressed because you can't take care of your kids, or you can't go to work, or you can't go to school, how do you fix that? So I would say that if that helps, giving examples of like that, treating symptomology versus treating the actual illness, that's how ME/CFS is severely lacking in actual treatment. So that's why research is so important. But thank you for your question, Sophia.
Thank you, Chetana. Thank you. So I'm going to ask Dr. Packer to please come on for a second. Any final thoughts or even impressions based on tonight? Because we are going to have to end soon, and we do have a little commercial announcement. So
Just,
please.
just how very proud I am of our students. I think over the 9 years we've graduated a good number. There have been at any point in time about 80 students in the program. I think we've seen about 180 over the 9 years. Every single one of them is passionate, interesting, and is going to make a difference in research in a variety of fields. I'm so pleased that we get to know them and watch them grow as individuals. I came back from retirement because of these kids, and I hope to see many, many more like them over the next several years.
Thank you, Dr. Packard. Thank you so much. And Grant and Chetana, we would love for you to be able to field all of the questions that we didn't get to tonight. So if you don't mind putting in the chat your email addresses, this way, all of the participants that have written questions to you can get the answers. And it's also really good mentorship because our PhD students are watching, our master's students are watching, and our undergrads are watching. And you are providing amazing mentorship for them, modeling what true research is about and modeling what true scholarship is. So I would like to, connect all of my students or any of our students with you, both of you, with the amazing questions that they actually put into the chat. So thank you both again. I hope to see you soon in the future, and good luck with all of your research. Thank you. And thank you, Chetana. So I'm going to actually have Jillian Leone come on right now. I made her a panelist and a co-host, and she should be able to share her video quickly. I know we're a little over time, but I'm just going to go for it because we just have to. But anyway, Jillian is one of our top cream of the crop, right? Cream of the crop. She's in the internship course right now. And she's also an officer in Alpha Phi Sigma, our Omega Tau chapter. And so this is a shameless plug. Jillian, take it away.
Okay, so hey everyone. I'm here to mention Alpha Phi Sigma, just as Dr. T said. So Alpha Phi Sigma is the Criminal Justice Honor Society. If you're interested in joining the Criminal Justice Honor Society at Nova, now is a great time to get involved. So this society gives you the chance to connect with other students, attend special events, and boost your resume, which can in turn be extremely helpful and give you a boost in your future career relations in criminal justice. So now to talk about the requirements. To qualify, you need a minimum GPA of 3.2 and be at least in your sophomore year of college. So being a part of Alpha Phi Sigma not only recognizes your hard work, but also gives you opportunities for leadership, networking, scholarships. So if you're curious or want to learn more, reach out to me. I'm going to put my email in the chat at the end.
Excellent. Excellent. I was just going to do that for you, but you go for it. That's great. Thank you, Jillian.
Yep. And I'd be happy to discuss it more and help you guide and help guide you any questions you have.
Thank you, Jillian. Thank you so much for being here, and thank you for being an officer. And what is your officer position?
I'm the IOC chair.
Yes, very important for any student organization. The IOC chair is very important. We also have Bailey North, who is the president of Omega Tau in the student organization that we have Alpha Phi Sigma on campus. And she's also right here, right now, participating in the live stream. So thank you again. And thank you again to all of the webinar attendees. Please make sure that once again, you email your instructor, email your professor that you were here tonight so that you can get that credit. And please join me next Thursday for a very, very special edition. I've asked Dr. Dana Mills to join me as we talk about 9/11 and we talk about some of the research and we talk about PTSD. Okay, so thank you so much. And thanks to our deans, Dean Durham and Dean Kushner and Dean Castro for everything that they do in supporting all that we do.